in the Delta. I'm sorry. And just a quick tribute to Beirut, my beloved city. It will rise again, and hopefully with all the hearted people that are helping in rebuilding this beautiful city. The blast was immense. As you can see, it was the second biggest explosion in the world after Hiroshima. So you had Hiroshima, Nagasaki, and Beirut. So you cannot imagine, no picture, no video will translate the problem and the extent of the damage that we have in Beirut and around Beirut. I would like to start with this book that we co-authored with Professor Nabil Barakat, who lectured on Monday. This is a book about fundamentals of implant dentistry. We wrote, along with Professor Roy Sabri, the chapter of implants and orthodontics, a symbiotic partnership. The new edition of the book was due to come on in quintessence in February 2020, but it has been postponed until 2021. Let's start immediately with the presentation. The presentation talks about the tooth and the string, but the tooth is the most important part of the whole procedure, as it is the periodontal ligament is the most creative tissue in the mouth. Because of the periodontium, we will be able to manage many defects, as you're going to see. The string that I have in mind is not the string that you have in mind. This is not the string that I'd like you to talk about. This would be the string I would like to talk about. It will be the string that is related to the function of stension and extending. And we will be using it not to pull out the teeth as we were kids, but to manipulate the soft tissue and the bone around it. Actually, this is not new. It was described in the mid-70s by Ingber, but Ingber talked about it in restoring the biological widths for the restoration, and then he talked about it for pocket reduction. But we have found that there are many, many other applications to this technique. We can erupt to save the tooth, or we can erupt to extract the tooth, and we will discuss different topics, and we will add at the end one topic more. So as we're going to start, we're going to regain the tooth structure, align the gingival margins, reduce periodontal pockets, and align teeth, or regenerate bone and soft tissue. And this is the most important part of the topic. We see how, with the limited time that we have, which is 30 minutes, how much we can talk about. So we can save the tooth and regain structure. Look at this patient who had presented with a trauma and a fracture of the central incisor. Usually when you have a central incisor or a tooth with a post, the fracture happens to the tip of the post. So it's so deep and it extends towards the palatal side deeply. So by extracting this tooth, we're going to lose a lot between the buccal and the palatal. Look at the X-ray. The extent of the fracture palatally is too deep, and there is another part that is broken on the buccal part. So extracting this tooth will make us lose a lot on the vertical, on the alveolar. So what did we decide to do? We decided to do an extraction. What are our treatment options first? Our treatment options are either extraction or implant, or we can simply erupt the tooth. When you see a gingiva like this, shrinking like this, it means that is unsupported. If we're going to extract, we're going to lose all the attached gingiva. And if we're going to go bone grafting, the mucogingival line will change, and many things will change. We'll lose papillae. It will be difficult to restore these papilla. So why don't we extrude the tooth? By extruding the tooth, we will be able to bring the soft tissue along with it. Look on the X-rays. Every week we activate the extrusion, and we will be able to bring the tooth all the way every week, and coming as close as you can see here, the white bar and the hook that is coming close to the white bar. And we will be able to save the tooth, not to extract it, but actually save it, connect it to the adjacent tooth, and it will last as long as it lasts. You're going to see how long it can last, because I'm going to show you cases that have been lasting for more than 10 years. In the clinical situation, look what happens. You can see that this is a shrinking gingiva. When the tooth starts coming, bone starts coming, and you can see that the bone is supporting the gingiva, and you're going to see that we have a very nice soft tissue and extension of the attached gingiva. At this point, we have two options. Either we do a periodontal surgery, but simply we can just do a fibrotomy. But doing the fibrotomy, we can just, without any major surgery, we can just cut the fibers before the bone has formed in this area. We will end up with the healing, and you can see what we have enough soft tissue, enough hard tissue, which is the tooth, for a ferrule that will consolidate the tooth and give us a very nice result. I would attract your attention to the mucogingival line that did not change. Actually, what we had, an extended attached gingiva around the two affected tooth. And this tooth will last very long because it has a ferrule effect that is around it. So what did we achieve? Saving the remaining tooth and a ferrule effect that will protect the tooth from fractures. Could it be applied to the posterior sector? Let's see here. We can see that we have an affected premolar, compromised situation. Patient has an implant on this tooth and it's suffering from a peri-implantitis. She refused to have an implant placed on this one. And she said, I'd rather preserve the tooth even though it is a very short tooth. Look what we can do. We were able to erupt the tooth. You see the number of threads that we lost on this implant. And the periodontist asked me to save this tooth. I said, okay. And I oriented the direction of the premolar towards the next premolar, away from the implant. And you can see that we locked it with a composite here, so we'll be able to direct the tooth, the eruption of the root, in a proper direction. As we said earlier, every week activation. Look what we were able to get. We had enough tooth structure, and we had enough attached gingiva. At the day of the crown placement, we have enough tooth structure. Look at the attached gingiva. Let me show you at the beginning how small was the band of attached gingiva. Look how much attached gingiva we gained in this case. Okay, so what did we achieve? Saving the remaining tooth, ferrule effect, and creating attached gingiva around it. Let's take it furthermore. Look at this situation where we have a fracture of the mesial root of the first molar. Do we extract the molar? No. Why don't we talk about hemisection? We cut the mesial root and we did a bridge from the distal root to the premolar, second premolar. And here, this bridge lasted for, as you can see, 9 years. And after 9 years, we had decay under the bridge. So what are our options? Extract the two roots, place two implants. This man is married to a dentist, and the dentist refused to do the extractions. And she said, can you save the tooth? I said, let's try. And here we did another extrusion. We're doing this extrusion. Why don't you look closely to the adjacent premolar? You see that this adjacent premolar has a kind of a hook that is touching the second premolar. If by any chance we would extract the second premolar, we might endanger the root of the first premolar. So what did we do? As you can see here, let's analyze the periodontium, and you can see that this root goes this way. So what we did the eruption. And by doing the eruption, as we said, on weekly basis, we were able to bring the tooth to a point where we would be able to use the ferrule effect, because we had enough structure of a tooth coming out of the bone, and we stabilized it double the time of the eruption. You can see the eruption did not take too much with the stabilization, from September 5 to 25 or 24 of October at the time of the stabilization. And then a couple of weeks later, we had the bridge done. So which is quicker, implants or bridge? Here is the bridge, and this bridge has been lasting for the last 4 years. Sorry, for the last 2 years, yeah, for now. What did we gain? We gained the tooth and we gained the ferrule effect. Look at this molar. Can we apply it to these molars? Yes, we can. This is an external resorption at the molar. And what are our options? Don't forget, this is a second molar that took the place of the first molar due to an early extraction of the molar. So this is an external resorption. If we extract the root, the tooth, don't forget we have an angular defect of bone. So we don't have a vestibulum in this area because the tooth is tilted and we don't have enough attached gingiva. What can we do? We can erupt. We do the root canal treatment. And notice also what we have. We have a proximity between 7 and 8 here in this distal part. So erupting the tooth with a direction that goes slightly mesial to bring it away from the wisdom tooth. This is our aim, and you can see here throughout the time what is the advantage of this on this molar. This molar has a one root and it's a conical root. We were able to move it very fast, very quickly to a point where we were able to restore it. Can you see what we gained? We flattened, we gained away, first of all, a distance from the root proximity. No more root proximity between the 7 and 8. The other thing is that we flattened the defect and there is no more angular defect. It's a flattened as if it is a kind of a pontic. We will see here, it's a similar case where we have also a tilted second molar that we tried to save, hooking to the implant. While the implant was having osseointegration, we were able to erupt the molar away from the wisdom tooth. And you can see here that we were able to save also this molar, creating a ferrule effect. Let me show you the clinical picture, and you will see that, look, the tooth with the eruption kind of aligned the gingiva. The gingiva was too low before. We had no vestibule. We had no attached gingiva. By erupting this tooth, we were able to create ferrule effect on the root that will protect the tooth from the fracture. Then we had to created a vestibule, and we have now enough attached gingiva that will protect the tooth. So gingival alignment, ferrule effect, and we recreated a buccal sulcus. So can we do more? Can we align the gingival margins? Yes, look at this patient. This patient presented with this ugly smile. She wanted to correct her smile. These teeth have suffered from recession. Okay, and you can see her smile. What can we do? Look at the upper right lateral incisor. How can we correct the length of the upper right lateral incisor? Can we do a apically repositioning gingival surgery on the 6 anteriors? Definitely not. The teeth will be like French sandwiches. They'll be very long. What they need to do is that we need to arrange the length of the gingiva and cover up more the lateral incisor. This is the clinical situation in the mouse. There is no way you will be able to cover this part of the root unless we use the biodynamics of the root eruption. The best bioengineering is orthodontics. And here we can see that this is the device that was placed from the palatal side, and we erupted the tooth, the lateral, to a point where we have it at the same level of the opposing lateral, contralateral, lateral. This is the device, very simple device. And look how we were able to manage her smile. And you can see these are the temporaries that are placed. And here are the finals. And you can see that everything went in order without having to do any kind of surgery on this anterior sector. Simply by erupting the teeth, we were able to manage her smile, as you can see before and after. gingival alignment, ferrule effect that will protect the teeth. And here we have a clinical photo of 14 years post-op at this today. Let's bring it to a more complicated situation where we have a premolar that is outstanding the alignment, and it has to be corrected for aesthetic reasons. What shall we do? We change the crown, we put another crown. It will be much longer because the gingival level is much higher. Why is this level shrinking? Simply because the tooth is tilted buccally and the gingiva will recess to the apical point, to the next narrowest point. And so what did we do? Again, we did the eruption slightly palatal. All eruptions have to be palatal to bring out the bone. If you do it buccally, you will lose the bone. You have to erupt it palatally, slightly palatally, to gain more soft tissue and bone. And here we can see that this is at the day of the placement. And then here is a couple of weeks later, and you will see that how much we gained at the level of the gingiva. Moreover, what happened here? Let's look closely. You will see that here was the preparation of the crown. Can you see it here? It's outside the gingiva. And what came out is the calculus. Because when we do the forced eruption, first of all, what happens? The tissue will not come unless you have unfolding of the gingiva. So the pocket will unfold. The minute we have the attachment at the tip of the gingiva, then the gingiva will come down with the bone. So this is the most important thing to remember. Here is the crown at the end of the treatment, the smile of the patient at the end of the treatment. So gingival alignment, tooth alignment, pocket reduction. Let's bring it to a more complicated situation. Interdisciplinary versus instant orthodontics. This patient has missing laterals and the canines took the position of the laterals with diastemas. He was restored with pink ceramic. The tooth is in the embrasure. How can we accept this? Look here. This is the situation complicated with the posterior support that is failing. So what did we do? We did a forced eruption to bring the canines to a proper level as the laterals, as they were supposed to be laterals. And on the other side, you can see here on the right side, on the left side, what did we do? We did it with a vector of mesializing the canine closer to the central incisor. As you can see here, we were able to close it and close the space and bring the tooth in a proper position. And there is no more pink ceramic to be placed. As you can see, the tooth was brought up mesial. And implants were placed in the posterior area. Don't be afraid. We avoided here the sinus. The implants are not touching. They are simply offset. One is palatal, one is buccal. And this is the final result of the treatment at the day of the placement. And you can see later on how it is aging with this type of smile that is a healthy smile without pink ceramic. What did we gain? Gingival alignment, tooth alignment, and proper tooth positioning. This is the patient, the happy patient. So can we do it to extract the teeth? Yes. Look at this fracture that is very deep on the buccal side. What happened is that if you're going to extract this tooth, we have and place implant, we need to bone graft the whole area, and it will compromise the adjacent teeth. Why don't we erupt the tooth? We erupt it. Look at the fracture. It's so deep. When we remove the buccal part of the fracture, you'll see that the healing was healing with a collapse of the buccal side. So there is no bone here. If we're going to do bone graft, we're going to compromise all the adjacent teeth and we'll have to change all the crowns of the patient. Why don't we erupt the tooth? We erupted the tooth, as you can see, to a point where we had enough papilla or excess of papilla in between. And you can see here at the end, What did we do? We extracted the tooth, we placed the implant, and we have more contact, bony contact between the implant and the tooth and the bone, simply because the alveolar is conical. When you erupt the tooth, it will be smaller, and the implant will fill up all the alveolar. At this point, we were able to place the implant, place the crown. As you can see, the lateral is here. We did not change any of the adjacent teeth. And look at the healthy papilla and the healthy gingiva around the tooth. Gingival alignment, simplified surgery, and prosthetic. More complex. I'm going to bring you to a story of this patient who had a central incisor, the upper left central incisor, with this type of bridge. The dentist did not look for the margins. So when I looked for the margins, the margins were very high, up high. And as you can see, there is no bony support, no tooth support. And the bone was at this yellow line. So what did we do? Another eruption, and you can see that we were able to bring the whole eruption down all the way, and you can see almost 9 millimeters down to a point where we saved the tooth. Why extract the tooth? And this tooth was saved. We would like to connect these kind of roots together, but the patient insisted on having separate teeth because she thought that if we would connect them, they would not look natural. This tooth lasted for 9 years. 9 years later, this central incisor suffered a fracture. It's time now to replace it with an implant. What did we gain? We gained a ferrule effect. We gained time before implant placement, and we saved the remaining tooth for 9 years. Now with this peri-implantitis, I'd rather save the tooth as long as I can before going into implant placement. And then we placed the implant when the fracture happened, and she was happy with the result. If we want to regenerate bone and soft tissue, this would be the same story of the same patient. Again, when we had this tooth between these two implants suffering from external resorption or root resorption and intrusion and root resorption. So if we are going to extract, we're going to end up with a gingiva.
Sorry, everyone. Dr. Nadim will be with us shortly after reconnecting. So please stay in touch. Dr. Nadim, can you hear us? Hello? Dr. Nadim, are you there? Sorry, everyone, for this inconvenience. Hello, Dr. Nadim. Welcome back.
Again, I'm sorry for this technical problem.
It's fine,
Hello.
Dr. Nadim. It's fine. We still have 6 minutes. Yes, we do, sir. We hear you now. We can hear you. Hello?
Okay,
Yes?
now.
Okay.
And we did the extraction. As you see the gingival level before the day of the extraction. The bone is falling up. And here, as reconstructed and calcified more than before. And today is not my day. I'm sorry. Any questions so far before we? Hello, hey, hello.
No questions, sir. There are nothing in the chat box. If there's anything, hello? Yeah, I can hear you clearly and I can see you. Hello? Oh.
Do you have any questions while we?
No, sir. No questions in the chat. You can continue, sir.
Bye. I'm going. Today is not my day. I'm having all the problems in the world. Okay.
We have 6 minutes. We have 6 minutes.
Okay. I don't mind, even if I stop now. I'm sorry. I'm having the.
No. It's our honor to have you, sir.
Thank you. A fracture on the left central incisor, and the patient has a very high smile line. So what can we do if we're going to extract? As you can see here. So probing goes all the way 15 millimeters down. So if we're going to end up with no bone on the buccal surface with 15 millimeters defect, it will be a very unhealthy and smile. So what did we do? We prepared the bridge and we started the eruption to a point where we had enough soft tissue. Can you see here? The soft tissue is much more than we started with. And you can see that this is the before and after, and the soft tissue is way down. Bone and gingiva.
The screen. Can you please share the screen with us? Because we can't see it. We can't see the presentation.
Yalla, you can see it. Okay. Okay. Shall I go back? This is back.
Yes.
So this is the. As you can see, and this is how much we gained in erupting for extraction. You can see here. This is the case when. This is Pontic that we recreated by eruptus. up with a healthy smile for the of the patient, without extraction, without extraction, without bone graft, and modeling with the root that was fractured. So gingival leavening, side development, everything can happen. We can also regenerate bone and tissue. This is the patient who has a central incisor to be extracted. When this was done without eruption, look what we ended up with. Major surgeries that we were needed to place the implant. As you can see, scar tissue on the lateral incisor with a defect on the papilla and on the midfacial aesthetics. So what did we do? Again, 6 months later, nothing was growing. Nothing was coming down. We waited a long time. Look what we did. We did eruption. And when they did the eruption, this is before the eruption on the X-ray. On the second X-ray, you see the eruption. Please note the peak, the bone peak that we gained above the implant. By erupting the tooth, we created a papilla. And this papilla, look here, this is the level, how many millimeters we gained. And to have a nicer aesthetics, as you can see here, on the before placement, implant crown placement. And you will see here that we were able to build up the midfacial and the proximal area and papilla of the patient. So this is the 7 years later. 7 years later. The teeth are weak, the teeth are good if you protect them with a ferrule effect, and you can see that the of the implant. What we gained is staying. Tools we have effect, and we have leveled the gingiva, and we restore papilla. So we have many advantages to this technique. To conclude my presentation, because the time was run, and I'm sorry for the technical hiccups. I had more cases. Is don't extract the tooth. A failing tooth is not a useless tooth. We can always use it. We can erupt it to build bone. We can erupt it to build papilla. We can erupt it to level the gingiva. But please act and place implants. This is not the technique that we'd like to use. We'd like to save the tooth as long as we can, and then later on, if the extraction will come, then we will extract the tooth. Thank you very much.